Welcome, Thriving in Aesthetics. We are here. It's season 5, episode number 9, a special edition on aesthetic considerations in the perimenopausal and menopausal patient. What a great day to be in Chicago, huh?
Yeah, it's like freezing cold. It's good.
And you got in late last night just for the show. We're super excited. This is a really current and hot topic. I don't think a day goes by where something doesn't come across my desk talking about the aesthetic considerations in the menopausal patients. And we have two fantastic guests today.
We do. We're so lucky. I mean, this is something that definitely has gotten a lot more light as celebrities come out talking more about their journey through menopause, making it a conversation now, something that perhaps people had a lot of shame associated with for many years. And we're going to be learning from our experts that menopause, although defined as something or a state where you lose your menses for over 12 months, is something that really starts to happen way before then. And so we're going to be hearing from two experts on what those changes are and what can be done so we can best support our patients through that journey. Because how many patients would you say are in their 40s or 50s or 40s or greater in your practice?
In my practice, it's the vast majority, but I'm a little bit older of a doctor, even though no one really believes that. But okay, I agree with you on that, but tell me, why do you think it's so current right now? I mean, it's from skincare to medical articles to journal articles to even the social media.
I think it's because celebrities are speaking out, whether it's Gwyneth Paltrow or others that are really popularizing or really speaking about their journey through this time. And perhaps we never really had people in the limelight that were so open about going through the changes.
I think people hid it in the past a little bit and didn't want to talk about it.
Perhaps we just didn't want to talk about it because it's associated, maybe, and we'll hear from someone who actually wrote a book on it. But
well, let me make an introduction on that.
Yeah, let's go ahead.
So we can get right to it. We are super lucky because we have someone visiting us today who's going to be a guest, Dr. Tara Ullman. She is a board-certified gynecologist, and she's written a book, The Menopause Confidential. And this is a best-selling book, so it's really exciting to have her talk about that. She is a Johns Hopkins trained, as well as SUNY and UCSF. She's the past president of the North American Menopause Society Foundation. She's coming to us from New York, and she's an expert on menopause, and I am super excited to have her give us some color to the concept of menopause. This is coming from someone who manages these patients from a hormonal level and even beyond, which really helps us to color how we look at it aesthetically.
Yes, and then we have Dr. Zoe Draelos, and we were talking right before we started the program. Everyone knows who she is when it comes to cosmetic dermatology and aesthetic medicine in the whole. She is someone that I've personally learned so much. When anyone goes through training in dermatology, you always read Dr. Zoe Draelos' work, especially when it comes to cosmeceuticals. She has published almost 700 medical articles, my goal, and she has authored over 14 books. She is clinical faculty at Duke. And she always provides so much insight on what topical applications of products can mean to the skin. So we're very fortunate to have her to kind of really give us that expertise on the influence of menopause on the skin.
Fantastic. Should we get to the disclosures and the...
Yeah, I don't know if our guests want to just say hello.
Oh.
Hello from New York City. Dr. Ullman here.
Fantastic.
Great to have you,
Carolina.
Wonderful. All right, so with that, we're going to get straight to it. Remember that at the bottom of your chat function, you can go ahead and your questions so that we can have an open dialogue today, and that's really where we all learn. And so with that, aesthetic considerations, these are our disclosures. Michael, if you can just move the slides. Dr. Stephen Dayan, myself, and I know Zoe, we do a lot of clinical research on many of the different products that are out there. And we speak for those companies. And so here they are. Dr. Ullman has no disclosures. Next slide. And this is for AKH. They are our CME provider, and these are their disclosures. Next slide. And we are very fortunate and want to thank our sponsors, both AbbVie and Galderma, for supporting this program today. Next slide. And so these are a bit of our objectives, the goal really to understand the various parameters to evaluate skin quality and the aesthetic changes in the perimenopausal and menopausal patient. some of the etiologies, specifically the hormonal fluctuations that occur and the sequence in which they occur in these patients, and then the ideal therapeutic options, not just but and devices that we use in our practice, in addition to hormonal supplementation, can really support our patients through this journey. Next slide. And so a little bit more about how you can get your credit after today's program, depending on whether you're a physician assistant, nurse practitioner, or physician, are listed here. Next slide. And so you can go ahead and do a screenshot or just take a photo of the QR code so that you can make sure to take the survey at the end of today's program so that you can qualify for your CME credit. Next slide. And so feel free to go ahead and ask questions throughout the program. We'll be answering throughout the program, not just at the end of the program. And perhaps no photography because some of these slides are the property of the people that have put them together for you. Next slide. We're going to be starting off today's program listening to an overarching view of the menopausal state, perimenopause and menopausal state by Dr. Allman. Take your questions and then move on to Dr. Zoe Drelos's presentation. Next slide. And with that, Dr. Allman's presentation. Thank you.
Good day, everyone. I am the great and powerful Dr. Tara Allman. I'm also a board-certified gynecologist in New York City and a Menopause Society certified practitioner, which means I specialize in perimenopause and menopause. It always comes as a surprise to women that not every gynecologist knows everything about midlife women's health. I'm sure that many of you have been with the same OBGYN for years because that's who delivered all your babies and knows all your secrets. Unfortunately, your OB may not be educated or interested in midlife women's health and therefore won't know how to help you navigate your journey through the wonderful world of perimenopause and menopause. Don't get mad or frustrated about that. Not every gynecologist knows everything about everything. For example, some focus on obstetrics and others on infertility or surgery, and some of us have chosen midlife women's health as our specialty. That's what I did over 30 years ago, and yes, I'm old enough to be your menopause doctor. I've had the most fun helping women navigate this important part of life, which brings me to some teaching pearls. There's a lot of mis- and disinformation about perimenopause and menopause out there. It seems that lately menopause is having a moment, and a lot of people are jumping on the menopause bandwagon to sell you all kinds of stuff to help you with your hot flashes, sweaty nights, moody blues, weight gain, dried up vaginas, and so on and so forth. So you really have to be careful when you're up late at night surfing the dark web for advice about why you can't sleep. Now get your pencil and paper out for another teaching pearl. The best and most scientifically accurate website to learn from on this topic is the Menopause Society's menopause.org. That's it. I just saved you a lot of wasted time. You're welcome. So today I'm going to explain the difference between perimenopause and menopause and why you should care. Perimenopause is the phase leading up to menopause. It usually starts in our 40s and lasts anywhere from 4 to 8 miserable years. The first thing women will notice is changes in their menstrual cycle from whatever they were to whatever they are now. You might be skipping cycles or having shorter or longer cycles or heavier or lighter ones. The bottom line is perimenopause is when your ovaries are winding down their duties, which include making estrogen, progesterone, and testosterone at just the right time, in just the right amount, and in just the right order. Since the perimenopause transition can take place over 4 to 8 years and can start in your late 30s and is associated with lots of the same symptoms that you experience with menopause, like hot flashes, night sweats, sleep disturbances, fatigue, mood changes, brain fog, weight gain, aches and pains, and dry skin, just to name a few, there is no blood or saliva hormone test that helps with making the diagnosis, because blood hormone levels are all over the place during perimenopause, and saliva tests are completely unscientific and irrelevant, despite what you read on the interweb. Now, treatment choices for the symptomatic perimenopausal woman are different than for the symptomatic menopausal woman, and that's why you should know which group you're in. Menopause is when your ovaries get to retire from their duties. At some point, your ovaries will stop making estrogen, progesterone, and testosterone. The average age of menopause is 51, but the range can be anywhere from 40 to 58. So that means you can be in menopause at the tender age of 40, which is at the beginning of the spectrum, or you can show off your ovarian function all the way to 58, and of course, most of us fall somewhere in between. Let's take a moment now to thank our ovaries for all their hard work and their many years of service to us. Thank you, ovaries. So the actual definition of menopause is when you stop having menstrual cycles for 12 months in a row. And you really can't know when your last official menstrual cycle is until a whole year has gone by. But you can definitely know that you are having terrible symptoms and you don't feel well or like the you knew and loved when you knew and loved you. And to be clear, menopause is when your ovaries no longer make estrogen, progesterone, and subsequently testosterone, and this has profound health effects on every bit of you, from your head to your toe, from your hair to your toenail, and absolutely everything in between. Now, I already told you that you don't need blood or saliva hormone tests to determine if you are perimenopausal, and the same is true for menopause. Unless you are younger than 40 and not having regular menstrual cycles, then a hormone blood test is helpful. Nor do you have to have your blood hormone levels tested if and when you decide to start hormone therapy for the treatment of your menopause symptoms. Blood levels don't help in the important decision process of what dosage to use for symptom relief, despite what you are reading on the interweb. Only you and your symptoms are helpful. And here's another teaching pearl. There is no such thing as being postmenopausal. Menopause starts with your last menstrual period and it ends when you end, when death do us part. So even though menopause symptoms might end at some point, this menopause phase of your life is your final frontier. There is so much to cover on the topic of perimenopause and menopause, so for the purpose of this talk, I'll just stick with the changes that occur to your skin. In Menopause Confidential, I cover skin health in the chapter called, Who is that wrinkly old woman in the mirror? Because that's what happens at some point in every woman's life when she looks in the mirror and is shocked to see an older woman looking back. Estrogen plays a vital part in keeping our skin moist and supple. As we age into perimenopause and menopause, and our ovaries slow down and ultimately stop making estrogen, our skin will become very dry, thin, crepey, wrinkly, and saggy. By the way, that goes for the skin of the vulva and vagina as well. In fact, 100% of vulvas and vaginas will dry and shrivel up if we don't take good care of them. That topic is covered in my chapter called The Vagina is Like Las Vegas, Baby. All kidding aside, estrogen is important for preserving collagen and elastin as well as maintaining skin moisture and thickness. It also reduces wrinkles and improves blood supply and blood flow. So besides staying out of the sun, wearing sun protective clothing and a great big hat and applying sunscreen everywhere except where the sun don't shine, you should know that one of the many benefits of using hormone therapy for the treatment of your perimenopause and menopause symptoms is also the health and wellness of your pretty skin. So I'll leave you for now on that note and look forward to a robust and informative question and answer period. Thanks very much.
Thank you so much. Are we back on? Thank you so much for that, Dr. Allman. Great insights. You say that you don't check any lab levels to confirm that someone's going into menopause. So one could expect, or when they refer out to somebody, an integrative medicine doctor or an OB that specializes in hormone replacement therapy, that just based on symptoms alone, they would perhaps just start them on broad hormone replacement therapy?
So just to clarify for the audience, perimenopause, you're still having menstrual cycles, but they are changing from whatever they were to whatever they are. So you're on a hormonal roller coaster ride. So today your levels might be high, but tomorrow they might be low, and next week they might be just right. And it's this erratic hormonal roller coaster that is causing the perimenopausal woman to be symptomatic. So the blood hormone levels don't help us. We know you're making some kind of hormones, you're still having some kind of cycles. The same is true in menopause. Your ovaries have retired. They're not making hormones. So we don't have to measure your hormones because your ovaries are not making them. We know they're low. And in terms of considering hormone therapy, we don't chase blood levels around to figure out what's the best strategy or dose for you. We chase your symptoms around. So based on are you flashing and sweating and can't sleep and mood and all the things that the perimenopause and menopause crowd experience, we don't need a blood test to help us figure out what's the best strategy for you.
But you will perhaps provide a blood test when someone begins on it to measure that their testosterone levels, if you're supplementing with testosterone, aren't going too high, and those effects that also have, I mean, there can be negative effects from too high testosterone. You wouldn't check that. You would just base it on whether the person's getting more aggressive and they're developing acne.
Now you're getting into a whole other world of testosterone. And in the space of midlife women's health, testosterone is not approved for women for any reason. So if we're going to consider giving a patient testosterone, it's only in the space of sexual health. And in that very limited group, where we might add in testosterone to a hormone replacement regimen to deal with their menopause symptoms, to specifically address sexual health, that is where measuring a testosterone level may be helpful as we go down, down the line. But that is not first line therapy. It's not FDA approved for use in women. You really, all listeners out there, you really need to find a specialist in hormone therapy accredited before you should consider using any hormone therapy for any reason.
Okay, and then there's always, I see a fair amount of my patients are an average age of about 47, right? So they're in perimenopause. Generally, I find that, and Zoe's going to cover, does our skin know that we're going into menopause before we do? Progesterone plays a big role when we're, young in causing acne because it's responsible for that oil production. But in our 40s and our perimenopause, it's generally what I see most patients get supplemented with first. Can you walk us through why progesterone is important, or perhaps what you start replacing in the beginning before you even have to go to estrogen?
So acne in perimenopause is always a shock to women because we went through it as adolescents and we absolutely don't expect to re-experience it as 40-somethings. And it really does have to do with the changes of hormone levels. It's not only about progesterone, it is about the imbalance of progesterone, testosterone, and estrogen, and the fluctuation. So the short answer, I think, to your question is, as an expert in midlife women's health who wants to deal with the symptomatic perimenopausal woman who has acne skin changes, the best solution for that group is to go on a continuous low-dose combined birth control pill with estrogen and progestin in it to help the perimenopausal ovary from doing its erratic job. It also provides contraception because the perimenopausal crowd can still get pregnant, and it just has enormous benefit to the skin on the face. And we do this for our adolescents, and we again repeat this for our perimenopausal 40-somethings. And I will just stress a new teaching pearl for your group. We use birth control pills in this group with their acne skin changes. We use birth control pills continuously, meaning no placebo week. It's all active pills every day of the week, every day of the year. so that we don't get skin breakouts. And then we send, if you need even more help with your skin health, we send you off to the dermatologist.
That's a question. Is menopause coming at a different age than it did in the past? I know menarche now is starting to come on earlier in Western society. Is the same thing happening with menopause? And if so, is it environmentally induced?
Is no change in the average age of menopause in this country from the time we started to pay attention. Really, women didn't live past about 50 back in the late 1800s. So the average age of menopause is still 51. The range is anywhere between 40 and 58. It's a big, big curve with most of us in the middle. And there has not been any appreciable change in that in terms of age regarding environment or anything else.
Something that, for the dermatologists that are watching, something that always gets a bit tricky, and we'd love your input, is for that patient that starts to, they're in that perimenopause, menopause, they're getting acne, and they just started hormone replacement therapy. Generally, we like to do spironolactone. But would there be a contraindication to that with the way that it perhaps modulates testosterone?
Well, spironolactone is a great choice, especially if you want to do it in combination with a continuous birth control pill. So if that's not in your armamentarium, dermatologists out there, if you're not comfortable doing both together, then collaborate with your gynecology colleague, because that is just an enormously terrific solution to deal with not only skin changes, which is what you're using spironolactone for, but all the other symptoms that the perimenopause group is dealing with, including sleep, including mood, including energy, including this and including that. So it's a combined 1-2. Everybody will be delighted with their skin as well as their very significant changes, symptoms during perimenopause.
But what if they happen to be on the testosterone? Some of my patients are, I'm in California, people are doing all kinds of things. And they're seeing integrative medicine doctors. If they're on testosterone as a supplementation because their levels are low, they're a little sarcopenic, is there a contraindication with doing spironolactone?
So because this is a science evidence-based talk, and I know that's what everybody wants, there really is no place for testosterone in the perimenopause crowd. They are making testosterone from their own ovaries. And in fact, women will make testosterone in menopause for about 5 years after they have stopped making estrogen and progesterone from their ovaries. So this notion that you should be giving women testosterone for sarcopenia or for energy.
For their sexual health
Yes.
are on it. So that's where the question comes from.
So the testosterone levels that we can get in labs are very inaccurate, and libido is very complicated. And so I will caution everyone thinking about putting their patients on testosterone for sexual health, really talk with a specialist in the sexual health space. It is not recommended. Again, the perimenopausal crowd is making sexual health is very difficult during the perimenopause transition. Women are really imperiled by the many symptoms that they face. You should really start there first before giving anyone testosterone. It's a much more nuanced, complicated issue.
What about some of the bio alternatives? I hear patients coming into my office like, well, I'm not taking the estrogen, but I'm taking this. And
Yeah, bioidenticals.
bioidentical.
That's what one of the questions here is actually.
So bioidentical hormone therapy simply means these following words: estradiol, progesterone, testosterone. These are just the hormones that your ovaries make when they're making them. And when you stop making those hormones, you can replace those hormones with estradiol, progesterone, and testosterone. There are bioidentical hormone therapies that are made in compounding pharmacies, and there are FDA approved bioidentical hormone therapies. They are neither safer nor better nor anything, but they simply mean the words I said, estradiol, progesterone, and testosterone. So they're great choices for the symptomatic perimenopausal and menopausal woman. I always recommend FDA approved choices because they have indeed significant clinical trials for safety and efficacy, and there's none of that support when you go to a compounding pharmacy. And you need compounding pharmacies for medication you can't get. You need to have a special compound made. But for hormone therapy, bioidentical hormone therapy, you have plenty of amazing choices available that are covered by your insurance company.
Okay, we have two more questions and we want to go to Zoe's. So Yaness is asking, with patients, there was that big study on people that had previously had breast cancer and not recommending HRT. And now that's been slightly refuted. What are your thoughts for us when we're recommending patients that are like, you know that they're going through perimenopause and now they're entering menopause. You're starting to see the changes. They're miserable, but they tell you, well, I have a family history of breast cancer. I'm not a candidate. What do we say?
Breast cancer is every woman's biggest fear when she's considering using hormone therapy. And the short answer to a very big and complicated question is that if you have a first-degree relative, mother or sister, who was diagnosed with breast cancer earlier than menopause as a younger woman, let's say in her 40s, you have to have a more thoughtful conversation and potentially get genetic screening. But if you have a family history of a grandmother or your mother or your aunt or somebody but older in their menopause years, that doesn't really appreciably change your risk in the eyes of a midlife women's health expert. So there's a lot of fear, way oversized fear about using hormone therapy vis-a-vis breast cancer issues. And I will say now something so exciting to your listeners that hormone therapy doesn't actually cause breast cancer. This is how it works. Here's the association. If you already have a breast cancer cell hiding in your breast that nobody can see yet on mammogram and ultrasound, and you consider using hormone therapy for your menopause symptoms, there's the tiniest chance that after 5 years, you could help your breast cancer cell to begin to grow. So it doesn't cause breast cancer, but it may be helpful in helping a breast cancer you already have to grow up. But that's after 5 years of use. There's nothing magical about 5 years. And the association is very, very small and loose. And so women should no longer fear. The pendulum has finally swung in the correct direction, where if you're a symptomatic menopausal woman with a remote family history, that is not a contraindication to using hormone therapy for your symptoms.
And so then another question here by Dr. Perez is, if somebody has had breast cancer like themselves, would it then be a contraindication? And this natural supplement, some people kind of do matcha and like other things that they say perhaps can stimulate grape seed extract to potentially, increase like testosterone binding. I don't know what your thoughts are. Can you provide some insight on somebody who's actually had it?
So for women who cannot or will not use hormone therapy for their symptoms, what other strategies is what I think you're asking? And you can try anything at all, is what I say. You can try everything. But if it doesn't work for you in 3 months, it's not going to. So that's the short answer. But I will also say that if you're a breast cancer survivor or very concerned because of a family history that is actually real and relevant, every woman can use local vaginal estrogen for the treatment of vaginal dryness and atrophy. And it's a very significant issue. Again, there's some fear. Can I use estrogen locally in the vagina? Because what if it travels over to my breast and potentially increases the risk of breast cancer? So to be clear for this group, local vaginal estrogen stays in the vagina, helps out the bladder a little bit as well, and will never leave that area. What's local stays local, and every woman, breast cancer survivor or fear of breast cancer, every woman should be thinking very deeply about vaginal health, or they will suffer immeasurably as they age.
Wonderful. Thank you for that, Dr. Allman. So thank you for the questions. I know we have a couple more, Lynn, Maya. Those are questions that are going to be answered, I think, in Dr. Zoe Drelos's talk. So we appreciate that. We're now going to be going on to Dr. Drelos's talk on the skin changes one can expect through perimenopause into menopause. And then again, any questions you have during her talk, please go ahead and put them into the chat function. Thank you so much.
Hello, my name is Zoe Diana Drelos. I'm very pleased to discuss the skin changes in perimenopause and menopause. I would like to disclose that I have been a consultant and a researcher for Alloy, a dispenser of hormonally based creams for perimenopause and menopause. Let's talk a little bit about the historical aspects of perimenopause products. Actually, prior to the development of the FDA, estrogen creams were the biggest selling cream in the market, and as a matter of fact, they were highly effective. They produced tremendous skin thickness improvement, but also produced facial telangiectasias. And it actually was because of these side effects of topical estrogen cream. This is one of the reasons why the FDA was found. So this was the very first challenge to perimenopause and menopausal skin cosmetics. But what exactly are the perimenopause and menopause changes that occur in the skin? Well, the ones that patients commonly associate with menopause are dryness, itching, thinning skin, wrinkles, and sagging. These are changes all related to estrogen deficiency, but estrogen not only affects the skin, it also affects the bones, which provide a framework over which the skin is draped, and estrogen is also protective against hair loss. Thus, estrogen really affects the entire external appearance of the woman's body. More specifically, what are the physiologic changes associated with estrogen deficiency? Well, skin thickness is reduced by 1.13% annually for each year post-menopause. Furthermore, the collagen content of the skin decreases by 2% for each postmenopausal year. Type 1 and type 3 collagen decrease by 30% in the first 5 years after menopause, and tropoelastin and fibrillin, which are found in elastic fibers, are also decreased. Thus, some of the most profound effects of estrogen deficiency are decreased elastin and decreased collagen. Menopause affects every area of the skin. It affects the epidermis, the dermis, and the hypodermis, or the subcutaneous compartment. It affects the stratum corneum, stratum granulosum, stratum spinosum, and stratum basale. It affects the sebaceous glands. It affects the collagen elastin fibers that we talked about. It affects the sweat glands, the nerves, and the hair follicles. Every part of the skin is affected by menopause. So what are the epidermal changes that are found in menopause? Well, the first thing that happens is we get increased transepidermal water loss, also known as TUL, which is indicative of decreased barrier function. It is this increase in TUL that actually results to the dryness that people associate with menopause. You also see atrophy in the epidermis. You see impaired wound healing. You see decreased antioxidant capacity, meaning that taking in vitamins and nutrients that function as antioxidants, but also applying to them to the skin is important. We see flattening of the dermal epidermal junction. This leads to senile purpura, this leads more to skin tears, but it also leads to thinning skin that is less strong to resist trauma. But estrogen also affects the immune system. We see decreased Langerhans cells, which are very important for surveillance of skin cancer in the skin. And we also see an increase in gray hair and lack of pigmentation or irregular pigmentation in the skin, which is due to decreased melanocyte activity. The dermal changes in menopause are equally as profound. We see decreased glycosaminoglycans, mucopolysaccharides, and specifically hyaluronic acid. This is one of the reasons why hyaluronic acid fillers and hyaluronic acid containing moisturizers have become so popular in menopausal women. We also see a decrease in collagen synthesis in the dermis, especially in two collagens, type 1 and type 3. As I mentioned earlier, we see a decrease in elastin fibers. But we also see an increase in matrix metalloproteases. Remember, these are collagenase and elastase. And so not only is there decreased collagen and elastin, but we also see an increase in the enzymes that degrade collagen and elastin. We also find in the dermis increased vascular instability. This is what leads to the flushing and the blushing, the rosacea-like symptoms that we see. This also leads to hot flashes associated with redness of the face. Estrogens are necessary for vascular tone to keep the vessels vasoconstricted. But without them, the vasos vasodilate, and that vasodilation is perceived as facial redness. We also see loss of subcutaneous fat beneath the dermis and the skin, with fat redistribution, especially to the internal organs, which results in a change in body habitus. As I mentioned earlier, menopause also affects the hair. The follicle is very estrogen dependent. That's one of the reasons why during pregnancy hair grows so well and so quickly. But after menopause, that estrogen drive is gone. The male type hormones in the female body become more prominent, thus leading to the onset of female pattern hair loss, which has a very similar pattern as male pattern hair loss, except that it spares the anterior hairline. So what are the treatment categories that are possible for menopausal skin? What can we do? Well, they're retinoids, they're moisturizers, excuse me, they're cosmeceuticals, topical hormones, fillers, energy-based treatments, and radiofrequency microneedling. Let's take a look at each of these treatments for menopausal skin one by one. First, let's talk a little bit about retinoids. Topical retinoids for menopause include prescription tretinoin and also tazarotene. Tazarotene has a much stronger retinoid effect. It is preferred in menopause over tretinoin. However, it can cause more irritation than tretinoin, and unfortunately, retinoid dermatitis is an unsolvable side effect of skin retinization. There are also over-the-counter retinoids that include retinol and retinaldehyde, and we'll take a deep dive into these in just a moment. Why are retinoids so important in menopause? Because retinoids induce thickening of the epidermis, they increase the height of the reedy ridges, they normalize melanocyte function, and increase dermal fibroblasts. All of the things that need to be upregulated that are downregulated by loss of estrogen drive. Retinoid receptors present in the skin also account for enhanced efficacy. And when you have a receptor that's activated, then you get a downstream cascading of all kinds of positive events. So you activate one receptor and you get a much broader effect. And that's one of the reasons why retinoids are so commonly used in the menopausal woman, because one receptor binding of a retinoid leads to many beneficial effects. But as I mentioned, irritation is unavoidable and the face does go through peeling, itching, stinging, burning for the first 4 weeks after retinoids are started. Retinoids are really the gold standard for menopausal skin. They can treat the acne, the hormonal acne associated with menopause. They can treat the skin hyperpigmentation and dyspigmentation associated with menopause. And they also can deal with the signs of photoaging that always accompany menopausal skin. There are a variety of over-the-counter retinoids that are also available for purchase. Retinyl esters are the most common retinoids in over-the-counter products. However, they have very high stability, which is why they're used, but they have really poor potency. Retinol is the next most common retinoid used in over-the-counter products. It has moderate stability. It has less irritation potential, but if you push it in doses above 2%, it can become quite irritating. But it too doesn't have a lot of potency. However, retinyl esters can be converted to retinol, which can be converted to retinaldehyde, which can be converted to retinoic acid. Retinaldehyde is a little more potent than retinol, but one of the problems is that it has a lot of irritation potential. And then finally, retinoic acid, better known as Retin A, is probably the most potent retinoid used in menopausal skin. What about moisturizers? Well, moisturizers are very important to restore barrier function, to decrease transepidermal water loss. Occlusive agents that trap in water, like dimethicone, shea butter, petrolatum, and lanolin, are important in menopausal moisturizers, but they must be combined with a humectant that draws water to the skin. Humectants act like sponges, and humectant ingredients include hyaluronic acid and glycerin. Photoprotection also can be put in the moisturizer to decrease photoaging. And moisturizers are the vehicle for cosmeceuticals, which are some of the most commonly used products for menopausal skin. Remember, we talked about how oxidative insults are much more dramatic in menopausal skin because they induce reactive oxygen species. Antioxidants, usually from the botanical kingdom, actually donate an electron to the reactive oxygen species, stabilizing the reactive oxygen species and decreasing its ability to damage the skin. So topical antioxidants are very effective, especially vitamin C, resveratrol, green tea, curcumin. All of these ingredients can decrease the effects of reactive oxygen species on the skin. Cosmeceuticals and menopause can also involve the use of peptides. Peptides are very popular, especially signal peptides, because they can increase collagen, elastin, and fibronectin, three of the things that are lost in menopausal skin. The most popular peptide in the current market is known as matrixyl. It is also has its chemical name of palmitoyl pentapeptide, known as PAL-KTTKS. It is a procollagen 1 fragment, but it in vitro stimulates the productions of collagen 1, 3, and 4. And remember, collagen 1 and collagen 3 were two of the collagens that were most degraded in menopause. It's used in 4 parts per million. It acts as a signal molecule, again, to cause a downstream cascading of many beneficial effects. Other more recently discovered substances that can function as cosmeceuticals in menopausal skin include growth factors and exosomes. Growth factors commonly used in cosmeceuticals, usually from spent fibroblast media, include transforming growth factor beta 1 that induces keratinocyte migration, epidermal growth factor that includes inducing epidermal proliferation. Now that's important because you get thinning of the epidermis in menopause. We have platelet-derived growth factor that induces macrophage activation and matrix production. And then finally, fibroblast growth factor that produces fibroblast proliferation and migration. So growth factors can counteract many of the effects of loss of estrogen on the skin. Exosomes are a newer entree into this area. They're basically extracellular vesicles. They're formed by fusion of an intermediate endocytic compartment, and that compartment is known as a multivesicular body. This multivesicular body then fuses with the cell membrane of another cell and releases the contents of the exosome. The exosome contents usually are fragments, particularly of DNA, RNA, and this is the way cells talk to each other and exchange genetic material. So if you, for example, provide estrogen to a woman who is estrogen deficient orally, it's possible that that could change the genetic messages that are sent between cells, and that could possibly make estrogen deficient cells act more like cells that have estrogen supplementation. So exosomes are one of the ways that cellular communication can be transmitted throughout the body when either oral or topical medications or over-the-counter products are ingested or topically applied. Now, we know the topical estrogens can be very effective. There are a number of articles to this effect. And I would like to present some research that I actually did looking at estriol and estradiol when topically applied. We did a randomized double-blind placebo-controlled study to look at topical estriol and estradiol versus vehicle. We enrolled 90 women in this study. They were randomized to one of 3 study arms. They either got estriol, estradiol, or just the vehicle in which the hormones were placed. The groups were balanced for age. They were between 50 and 60-year-old women. All Fitzpatrick skin types were enrolled and all photoaging severity, but the groups indeed were balanced. I assessed, and the subjects assessed, efficacy of the topical estrogen on a 5-point ordinal scale. We took photographs. We did non-invasive assessments. We wanted to look at skin hydration. We wanted to look at transepidermal water loss. We wanted to look at elasticity, and we wanted to look at pigmentation. All of those are characteristics of skin that is estrogen devoid. The same activities and the assessments occurred at baseline, week 4, week 8, and week 12. What did we find? Well, there was no statistically significant difference between estriol and estradiol. They both worked very, very well. We also found that there was no increase in serum levels of estriol or estradiol, indicating that the topical formulation was not systemically absorbed, which is very important. But both the estriol and the estradiol produced significant increases in skin water content after 12 weeks of product use. This means that transepidermal water loss was decreased, and this means that the water content of the skin was increased. The estriol cream demonstrated a statistically significant 48% improvement in radiance. There was a 50% improvement tactile roughness, a 57% improvement in visual roughness, 70% improvement in hydration, 88% improvement in skin elasticity, and a 68% improvement in overall skin health. Similar findings were found with estradiol, and we found no statistically significant difference between estriol and estradiol, but both were found to be very effective topically in improving appearance. In addition to topical agents, there are other procedures that we can use in women who are either peri or postmenopause. Hyaluronic acid is a wonderful solution as the skin thins. Due to lack of estrogen, hyaluronic acid can restore facial volume. The filler can be placed deep on the bone itself for facial contouring, basically to take up some of the excess skin that can form marionette lines and jowls. Fillers can also be placed in very fine lines around the eyes to restore dermal thickness, and can be placed broadly across the cheeks to restore and lift the cheek area. Other non-hyaluronic acid fillers that are biostimulatory can also thicken the dermis and lead to more permanent, long-lasting collagen regeneration. Thus, both types of processes are used, and both types of fillers are used. There are a variety of energy-based treatments that can also be used in menopause. Laser resurfacing can improve pigmentation issues and skin texture. Columnar laser destruction, such as Fraxel, can create columns of healing and induce collagen regeneration. And finally, intense pulse light can be used to decrease telangiectasias and improve pigment irregularities. These procedures can be used alone or in combination with one another for improvement of the menopausal skin. Radiofrequency microneedling is also used commonly in menopause. It also creates columns of damage, but here you get physical damage from the needle puncture, and then you also get electrical damage and a burn from the radiofrequency. A lot of times these procedures can be combined with ultrasound. You can ultrasound image the skin, and that ultrasound image allows you to look at skin thickness, and that allows you to know where to place the needles for optimal placement. You can also use radiofrequency microneedling to enhance the delivery of topical products, such as topical estrogens, antioxidants, growth factors, etc. So what can we say in summary about menopause in the skin? Well, the effects of estrogen on the skin are huge, as this very brief list shows. Our interventions are somewhat limited, but we can use fillers. We can use energy-based light sources. We can use radiofrequency microneedling. We can use topical estrogens, moisturizers, cosmeceuticals, growth factors. We have quite a plethora in our armamentarium products to use. None of them are perfect. None of them totally reverse the perimenopause and menopausal symptoms, but this is where we stand today, and I hope my presentation has been helpful in giving you a survey of the various treatments for the skin changes found in perimenopause and menopause. Thank you very much.
Thank you so much, Zoe, for that in-depth discussion on the effects of menopause on the skin. I love your study. I think that I'm sure you get asked all the time about the topical use of estradiol or estriol based on your study. And a lot of women are always a bit concerned about the systemic absorption of topical use on the face. And if you'll recommend it to somebody who still has had a personal history of breast cancer, can you just kind of elaborate on that?
This was a compounded product that was compounded by a pharmacy that produced it for the study. So the product I studied, basically you would get from your dermatologist or your gynecologist via prescription, and then it would be filled by a compounding pharmacy. So to be sure that it wasn't systemically absorbed, we did do systemic levels, and that was reassuring that we saw no change. However, this was a research study, and so we eliminated all women that had a history of breast cancer or any other female cancers, uterine cancer, ovarian cancer, etc., because we don't know the answer to this question. They were not considered to be good research subjects. So I really can't comment on the use of these creams in women with pre-existing cancers. However, since this is a prescription item that would be gotten by a dermatologist or gynecologist, they would really want to evaluate the woman's past medical history and be sure there are no risk factors in their mind for topical compounded estrogen products.
Yeah, but it's not FDA approved, right? And there's a lot of my patients who are getting it from these, places that maybe aren't as reputable or aren't spending as much time investigating the patient's past medical history. Do you have a general philosophy on using this topical and what the average person out there who's treating aesthetic patients should consider?
Are no FDA-approved topical estrogens. Many people are using the vaginal estrogens on the face.
Mm-hmm.
That is being done. This is really a research project. It was basically to document, is there a difference over vehicle? A lot of studies using topical estrogens that have been published are completely uncontrolled. In other words, you give one group estrogen, you give one group nothing. And that, a lot of the vehicle effect in dermatology is very important because that improves the skin barrier. The estrogen was placed in a moisturizing product. So you're going to see improvement transepidermal water loss just from the vehicle. So here we use the vehicle as one arm and then the actives as our other arm so that we could kind of ferret out what was vehicle effect and what was actually drug effect.
And then, Zoe, since both were kind of equivalent, the estradiol and the estriol, which one do you recommend in practice topically? Which one do you prescribe?
They were found to be completely equivalent, which I thought
Yeah.
was very, very interesting. Now, it could have been that there were smaller effects that we weren't really able to pick up. It's also possible, the study was run in a relatively short period of time. It'd be interesting to know what happens after 6 months of use or what happens after a year of use. Would we have seen some other differences? So really what you're looking at is penetration into the skin, and then you want it to stay in the skin, right? You don't want it to wash out and be systemic. If that were the effect, you'd want to take it orally. So this is the first controlled study I've done on this. There are some other estrogen-like compounds that are currently marketed, like Emapel, for example. Those are not true estrogens. This is the first study I had done on basically a true estrogen instead of estrogen-like products. So based on the research project, it's hard to answer definitively what to do, but we do have some early data indicating that topical estrogens do provide benefit above and beyond the moisturizer in which they're placed.
I just think we have to be careful with this,
Yeah.
because I see a lot of people maybe abusing this and quick to prescribe this or do this, not necessarily knowing what kind of product they're putting on their skin. And I don't, I'm a plastic surgeon, so I'm kind of a caveman when it comes to this stuff, I guess.
But yeah, people
Yeah,
that are in their 30s or people that are not even, I guess like Dr. Allman talked about it being symptomatic. So when you're symptomatic, we start doing things. But if you're in your 40s and you're not symptomatic and you think you have a little bit of dry skin, is it appropriate to be prescribing this topical estrogen product for the face?
These are prescription products, so they are
Yeah.
regulated, and I think that regulation allows physician oversight. Um, and the physician needs to make their own decisions. But if the person just has dry skin and hormonally they're intact, probably a moisturizer would be a better choice than a moisturizer containing estrogen. I think these products, and we study them, in women 50 to 60 years old. So these women had been in menopause for a while, some of them. And what's really interesting is the longer you're in menopause, the estrogen receptors in the skin actually disappear.
wow.
So it may be that it's necessary to take a close look at decades, 50 to 60-year-olds response to estrogen topically, 60 to 70-year-olds response to estrogen topically, 70 to 80-year-olds estrogen response topically. And I've never studied that older cohort of women in their 70s, 80s, and beyond. But the thinking is that as estrogen receptors decrease due to inactivity, that the older woman may not be as susceptible or receive the benefits from topical estrogen that a younger woman might. But that all that work needs to be done.
And it might be because it's also just chronologically because of age, their cells are becoming more senescent. So I think that that's the role also for what we do in aesthetic practices, whether it's the injectable hyaluronic acids or biostimulators. We did a trial to show that PLLA, for instance, does increase adipocyte-derived stem cells, which we know become a little bit sleepier with age, and then can go on to become either like adipocytes or even fibroblasts. And so based on work that was done by Krugloff, showing that perhaps when we're injecting these products, the thought has always been that they're just serving as scaffolds for fibroblasts to kind of stretch onto. But perhaps really what we're doing is also stimulating our stem cells. And if we're stimulating our stem cells to become or proliferate into adipocytes or into fibroblasts, then you have a target for your topical estrogen. You have a target for some of your energy-based treatments with heat shock proteins to stimulate more collagen. But if you have a very sleepy milieu, your environment is senescent, then you don't have as much of a target to what you're talking about.
Right. I think combination therapy is the name of the game, and that's why I introduced all those modalities in my talk. I think you would pick and choose and customize for each given patient, but I don't think topical estrogen is the end all for menopausal skin.
Can you reverse with these treatments that you're recommending? You mentioned some of these collagen losses and all the things that happen during menopause. What if someone hasn't attended to their skin 5, 6, 7 years later after menopause, they decide to start doing treatments? Can you reverse the effects?
Well, it depends on where they are. Are they 55 or are they 75? And then it also depends on, how much hormonal influence is on the skin versus photoaging. In other words, how well have they cared for their skin during their lifetime? Because all of aging, intrinsic and extrinsic, is found at every decade. And so if you had a lot of sun exposure, you have more elastin collagen damage, you might treat that person differently. Maybe CO2 laser resurfacing would be what's necessary. Whereas someone who's had less photo damage might be able to use a retinoid in combination with a prescription estrogen cream and do quite well.
Great. And then you were talking about drug delivery of these topicals with potentially like microneedling. Is that something that you do in practice?
I actually do not deliver drugs with radiofrequency microneedling for two reasons. One
Mm-hmm.
is the question is, do you put the medicine on first and then microneedle, or do you microneedle first and then put the medicine on? So if you microneedle first and then put the medicine on, the skin has tremendous elastic potential, and I believe those pores close right up. And your delivery is very minimal if you do microneedling first and then put the product on. Now, the flip side, where you put the product on and then you microneedle, for example, in these prescription estrogen creams that we were studying are all kinds of preservatives and stabilizers and buffers. So when you're microneedling, you're actually microneedling the emulsifiers, you're microneedling the preservatives, you're microneedling all these things into the skin that were never intended to go into the skin. They are ingredients necessary for product stability on the skin. So I worry about that. However, if you have a serum that's specifically designed for microneedling, that's devoid of preservatives, devoid of emulsifiers, devoid of any irritants or allergens, you might be able to use that. But as you know, Sabrina, those are hard to come by. And the
Yes.
reason they're so hard to come by is because there's no preservatives in them. They're not stabilized. So their shelf life is only a matter of weeks. So I'm more for do the microneedling procedure and then let the skin heal and then use your products appropriately, because you can get as good penetration from a penetration enhanced product as you can from a microneedling post application of an active.
We have two questions
I
here.
would ask one more question.
Yes.
In light of the GLPs right now, Zoe, and fat, and we know fat and estrogen have a direct relationship. What are your thoughts on people's fat and estrogen and the replacement and the GLPs? Do you have some insights?
Well, estrogen is stored in fat. So when these women lose their fat stores through GLP use, they actually undergo a tremendous hormone change. And
Mhm.
and that's very interesting. It's not been well documented. It's not been well discussed. But I do think you need to reevaluate a woman's hormone status after using GLP-induced weight loss products.
And skin changes as well, probably.
Absolutely, a lot of sagging of the skin. There's muscle loss as well. And most people post GLP actually have fairly poor skin quality. And that's a whole
Yes.
area of active research right now.
Yeah.
I couldn't agree more. And so then, Zoe, to your point, since some people are trying to go and then just like microneedle these topicals, and I love that you're on talking about the potential thing that you're introducing to this in the dermis, which was not intended to actually be in the dermis. What are your thoughts of then just like an injectable, the injectable HAs that are meant to kind of boost the skin, like dermal hydrators, gels that are truly intended to be injected into the dermis to restore some of that glycosaminoglycans that we're losing because of fibroblast senescence. Is there a role for that in restoring some moisture content to the skin in people that are kind of going through the shift?
Well, the best way to restore skin moisture content is basically to put an inclusive barrier on top, so that you don't
Okay.
get transepidermal water loss, so that the water stays in the skin and doesn't, through osmotic imbalances, go into the environment. But I think hyaluronic acid injections are really one of the best ways to restore volume to an aging face. And because they soak up water, they very naturally hydrate the dermal compartment of the skin, as well as reside some in the subcutaneous compartment when you inject. So I think the hyaluronic acid fillers are really great. I think what's really needed, excuse me, for total reconstruction of the skin is microinjections of hyaluronic acid very superficially in the skin. And that technique has not yet really been refined. We need an injector and we need a very thin product. And I know there's some under development, but none of them provide the even texture of the skin that you're looking for. So we need to figure out a way of trying to get hyaluronic acid into the viable epidermis and dermis. And a lot of the multi-molecular weight topicals are trying to do that with your higher molecular weights that attract water to the skin surface, your mid-molecular weights that reside deeper in the stratum corneum, and then your smaller molecular weights that can penetrate into the viable epidermis and dermis, and all soaking up water. So giving you this layered benefit to topical hyaluronic acid application.
Great. And then last question, I appreciate both of you and your time today. Dr. Maya is asking about how you address hair loss in the menopausal woman.
Well, the first thing you need to do in hair loss is be sure that it's due to estrogen deficiency. A lot of women are ferritin iron deficient. That needs to be checked. A lot of women are copper deficient. That needs to be checked. A lot of women are on vegan diets with insufficient protein sources. That needs to be checked. A lot of women are taking testosterone. That needs to be checked. You need to look at what the hormone status is of the woman. And then once you've ruled all that out, basically estrogen deficiency or female pattern hair loss is kind of a diagnosis of exclusion. And then once
Yes.
you get there, provided you've ruled out everything else, then you can address your topical minoxidils. Then you can address hormone replacement. Then you can address some of the other issues that contribute to hair loss, like thyroid disease obviously needs to be checked. Any other systemic diseases need to be ruled out.
Okay, I'm going to add to that. I agree to to your point, and to Dr. Maya, who asked the question. Also, taking a look at vitamin D is important. And I couldn't agree with you more. Ferritin, Zoe, I've commonly see that it might be normal based on lab reference ranges, but you ideally need it to be at least greater than 70 for it to actually be having an effect to improve hair quality. And I see that it's low in a lot of women. So once you're optimized there, then I think that even the treatments that we offer, whether it's PRP or now there are energy-based laser devices, there's always been the red light therapies, but now there's even lasers that are getting approved for the use, whether it's a 1927 nanometer laser or a 1565 nanometer non-ablative laser that are being used to increase hair density. But I think the environment in which you're delivering these treatments first has to be evaluated. So,
Great.
yeah.
All right, we're up against time.
Yes. Well, thank you both. We really appreciate you joining us today and lending your expertise. To all the people that asked questions, we really appreciate it. I know that I didn't get to two of them, and you can message us later and we'll get to those. But thank you, everyone.
Also, fill out the survey and get your CMEs. You got to do it now if you want to get it. And this also will all be transcribed into a published paper, so you'll get more information if you want on this episode.
Wonderful. Thank you so much.
Thank you.